Good afternoon, everybody, and welcome to this CASLPO e-forum on the practice standards for audiological assessment. Thank you for taking the time to be here with us today. So just some quick reminders before we get started. We recommend that you close other running applications on your computer to help maintain a stable connection to the webinar. If you have any technical issues at all, try exiting the session and returning using the link in your email. And the recording and slides for this webinar will be posted on the CASLPO website shortly after this presentation under Events and then eForums. If you have any questions as you're listening today, please type them in the box on your screen. My colleague Sarah Chapman-Jay will be monitoring those questions. And we will stop for questions during the presentation and at the end. And the practice standards that we are discussing today are attached as a resource in this webinar in both English and French. So if you'd like to click on that document and open it up and have a look at it as you're listening, you can do so. So my name is Samita Joglekar. I'm the Audiology Advisor and Manager of Mentorship at the college. And I'm very happy to be joined by two of my colleagues this afternoon, and I'll let them introduce themselves.
Hi there, I'm Dana Prucci. I'm the Director of Professional Practice and Quality Assurance and a speech-language pathologist.
And hello, everybody. I'm Sarah Chapman-Jay. I'm an advisor for speech-language pathology, professional practice, and quality assurance. So back to you guys.
Thanks, Dana. Thanks, Sarah. So here are the topics that we'll be covering in today's e-forum. We're going to start with why and how the practice standards were revised. Then we'll give you an overview of the revised practice standards. I'm going to talk about some significant changes in the standards that you should be aware of. And then we're going to go through some scenarios that will help us apply the practice standards and, of course, take your questions. So we'll move into the first section.
As Samita said, we're going to talk about how and why the practice standards were revised. So the only tool that the college has to protect the public is to regulate the profession. Creating and revising practice standards are important parts of how CASLPO regulates audiologists. This is the definition of practice standards. Practice standards are the bar that must be met, with minimal expectations for registrants to meet. Registrants can exceed the standard, but cannot fall below. These are not aspirational, and the practice standards are intended to reflect practice trends and the changing practice environment, practice advice questions that we receive, and technological advancements. So for example, there was a sudden spike for virtual care during the pandemic where the college realized that standards were needed. The expectations are that audiologists will meet the line in the sand. We want the bar to be attainable for all audiologists in all environments.
Great. So up until this point, there were two documents that CASLPO had for audiologists in terms of practice standards and guidelines for assessment. There was one document for adults and one for children. And both of these documents became effective in 2008. So these were the standards for the profession up until this point. So the Practice Matters Committee of the college prioritized the review of these two, we call them PSGs for short, for a number of reasons, and I'll tell you what those reasons were. So the first was that looking at both of the PSGs, there was quite a bit of repeated content, and the content, as well as the standards in those documents, didn't really speak greatly to any differences that would exist when conducting the assessment of an infant or a child versus an adult. And another reason for the revision was that some of the content was quite instructional instead of being principled. So as Dana just explained, practice standards have to be principled because they have to be the minimum expectation for every audiologist in every setting. So they need to be broadly applicable. And the content being too specific or instructional was taking away from that principled approach. It's no surprise that after 13 years, the information in the PSGs was outdated and needed to be updated. And the fact that the information was outdated was leading to a lack of flexibility. So for example, in the previous PSGs, it said that you must have a full range dual channel diagnostic audiometer. It talked about very specific emittance testing equipment, and the implication was also that all assessment had to be done in a soundproof booth. So in the last 13 years, there have been lots of technological advances in audiology and lots of changes in the profession. We have better portable equipment, better technology overall that can help us gather accurate and reliable assessment results. And in addition to that, the public is needing more assessment within the community. So the ability of audiologists to go into retirement homes or go into a patient's home or go into a school to do screenings for students. This is becoming increasingly important. And so that lack of flexibility in the standards also needed to be addressed to speak to more current situations that the profession is facing. And then this was also leading to some relevance concerns. So there were questions from the profession in terms of what the minimum expectations were for audiologists when conducting an assessment. So this all needed to be clarified.
When the college revises or creates standards, there's research and consultation that needs to happen. For this standard, research included an environmental scan of 12 colleges, specifically their assessment standards. Do they even have standards on assessment? What we found was very interesting. Only the colleges in orange had standards on assessment. Overall, assessments are expected knowledge of the professionals in the entry to practice competencies. Those that had standards were very high level and principle based. And they also did not distinguish between the assessments of adults and the assessments of children. So following the research, it was decided that we would keep the standards, but make some significant revisions.
So based on that research and consultation, the standards were revised with 7 objectives. So the first objective was to combine the 2 documents into one standards document with broad level principles that would be applicable across all settings and all populations. And that's the document that we're reviewing today. A second objective was to shorten the document in length and improve the clarity of the information by eliminating some of the prescriptive content. So the practice standard document now is 12 pages of reading instead of 35 pages that you would have been reviewing with the 2 previous PSGs. Another major objective was to update the standards to improve relevance and reflect current practice, as I described. And then another objective was to place emphasis on your professional judgment to make reasonable decisions. And we're going to talk more about this when we take a closer look at the standards themselves. A very important objective always with the practice standards is to focus them on risk of harm principles and to ensure that the standards will stand the test of time. So they need to be still relevant in a number of years and looking into the future. The entry to practice competencies for our profession were integrated into this practice standard. And then finally, to ensure that the standards apply to all patient groups in any location, including remote communities. So after doing the research and consultation with the different colleges and drafting the revised set of standards, the draft went to an advisory working group. And this was a really wonderful group of 10 audiologists who participated. And you can see here some of the details of the group of audiologists that we had. So they brought a very broad range of clinical experience. It was very important to us to have audiologists who had experience working with infants and children and in different practice settings, working with different populations, and also bringing a different numbers of years of experience. So we had audiologists who had just started practicing in the profession and those who had been practicing for up to 30 years. And the role of this group was to really do a deep dive into the drafted practice standards and to give us feedback because these were audiologists who are out there every day practicing, interacting with patients in these different settings. So it was very important for us to hear from them whether they felt that the standards represented the profession. And so we asked them questions like, does this standard represent current audiology practice? Will it stand the test of time? Does it clearly explain the minimal performance expectation of an audiologist? And does the standard address risk of harm? And then, of course, it was very important that we hear from them if there was anything missing. And so taking all of their feedback, we implemented that in the standards and then took it back to the Practice Matters Committee. And then the revised standards went out for a stakeholder review. So you might remember receiving emails from CASLPO when the standards went out for your review. And 116 audiologists participated in this stakeholder review. And greater than 95% of the audiologists who participated agreed with the following statements for each standard, so that the standard was clear, that they could implement it in their practice, and that the standard protects the public. And we also asked for agreement with this statement. So do the standards represent the current knowledge, skills, and judgment required to provide audiological assessment to patients across the lifespan? And 94% of audiologists said that they strongly agreed or agreed with this statement. So that was a very positive stakeholder review. And the practice standards for audiological assessment also went to a group called the Citizens Advisory Group. So this is a group of members of the public, patients, family members, caregivers, and so on, who had the opportunity as well to read the practice standards and give their feedback. So they gave us feedback on things like, are the standards understandable? Are they helpful to the public? Do the standards help the public understand what an audiologist should be doing when they conduct an assessment and what to expect from an audiologist when they get their hearing tested? So another thing that the college is doing is producing companion documents for the public to go along with the practice standard. And we've also attached this document in the webinar as a resource if you'd like to have a look at that document for the public. And it is being translated and will also be available within a few days in French.
The practice standards have been effective since October 1st after approval by Council. They will be required reading for audiologists on the self-assessment tool in 2022 with the Code of Ethics. So when you log into your SAT in January, there will be a message saying that these are both required readings for you. In addition to having them attached to this webinar, we also have them, of course, up on the website. And the way that you can find them is by going to CASLPO.com and clicking in the top right on Resources. Then you can click on the middle box for Standards and Resources, which will take you to more boxes. You can click on Audiology Practice, and under Audiology Practice, you can see the standards in English and in French, as well as the public-facing document that was helped to be created by the Citizens Advisory Group.
Great. Okay, so let's move into the next section of the presentation, which is to give you an overview of the revised practice standards. So if you look at the document, you'll notice that it begins with guiding principles and definitions. And this is one page. It's some important information because it sets the context for the practice standards and also explains how to think about the standards. So it's a important one page to go through. And then there are 15 practice standards. So they are all must statements that define the minimum performance level required. And then underneath each standard, there are competencies listed that describe the actions and behaviors required to meet the practice standard. So let's take a look at some of the definitions in the document. So we've already covered the definition of a practice standard. The definition of competencies is the knowledge, skill, and judgment required to meet a standard of practice. the definition of risk of harm, and that is that risk of harm exists when a modifiable behavior may result in a specific adverse event that is likely to impact a patient in several ways. So in this case, what is the modifiable behavior we're talking about? It is how you go about conducting an assessment. So what is important for the assessment? How are you planning the assessment? And the considerations that you have to make to ensure that it's going to be a safe, effective assessment that mitigates risk of harm. And that's what the standards are all about. And then the definition of reasonable. And this is an important definition to keep in mind because you'll notice in the practice standard that it says things like make reasonable attempts to conduct emittance testing, speech audiometry, or it might say use your professional judgment to make a reasonable decision given the unique circumstances of your patient. So the definition of reasonable is what a hypothetical, typical audiologist who exercises average care, skill, and judgment would do in similar circumstances and thereby serve as a comparative standard. So in the definitions, there's also a definition of patient and intervention, which you can have a look at. So let's now take a look at the standards themselves and what they are about. So in section A, there's one practice standard, and this is on determining an effective approach to assessment. Section B has 3 standards for resource requirements, a standard on having adequate resources, which includes equipment, tools, and technologies for assessment, a standard on making appropriate referrals when you don't have the resources that are needed for the assessment, and then a standard on remaining current. In section C is risk assessment and management, and this is one standard that has to do with identifying, addressing, and mitigating risk of harm. Then section D has all of the remaining practice standards. So a standard for consent for all aspects of assessment, and that includes obtaining and documenting consent. The standard for case history. And then standards 8 to 11 include the statement, make reasonable attempts to. And these are the basic elements of an audiological assessment, according to professional consensus. There may be other procedures that you are including in the assessment, depending on the patient population that you're working with, and those are addressed by the principles in these standards. Looking at the last few, there's a standard on education and counseling, further intervention, documentation, and then a standard on virtual assessment prior to initiating, ensuring that a virtual assessment will be feasible, appropriate, and reliable, given your specific patient. Okay, so now I'd like to tell you about some of the significant changes in this practice standard that you should be aware of. So a first major change is that audiological assessment outside of a soundproof booth is no longer a clear deviation from the standard. As I alluded to before, it was important to update the standards in this way because of some of the technological advancement that's happened in the profession, as well as the changing needs of the public. So going into a school, going into a patient's home, retirement and long-term care homes, this is something that can be considered. Of course, if you are going to conduct any type of assessment outside of a soundproof booth, the standards would say that you must ensure that you have the appropriate equipment and that you can meet all of the other standards that are required and that are described in the document. Another significant change is that there is a practice standard for virtual audiological assessment, and we'll be looking at that standard more closely in the scenarios. This is an ongoing area of development in our profession, and so this standard speaks to being future-proof, having standards that will stand the test of time and still be relevant in a number of years. In terms of how the standards are actually written and what they look like when you read them, you'll notice a change is that you have the practice standard, and then underneath you have a set of competencies. and that is a difference in how the standard is written. As I mentioned, the standards cover audiological assessment across the lifespan, so from infants to the elderly. And then the standards are principle-based and they rely on your professional judgment. So what does that mean? It means relying on your knowledge, both professional and patient-specific, when you are applying the practice standards. Considering the specifics of the situation. So who is your patient? What are their unique characteristics and needs? What do you know about them? What is the service that you're providing and what is the context? So drawing on this knowledge as well is part of your professional judgment. It's also your skills, education, and experience that you're drawing on. It's about seeking peer feedback as well and looking at professional consensus and evaluating your decisions, which is a part of clinical reasoning skills. So that brings us to the end of this first section. At this point, we can take some questions.
Thanks, Samida. Yeah, so we have a couple of questions. So one of them is there any plans to revise any other audiology standards?
So thank you for that question. So it's the Practice Matters Committee of the college that directs the revision or creation of practice standards. So it may be that this committee will be looking at other standards that are relevant to the profession that need to be revised. It really is a question of, is there a significant change in the risk of harm or in the practice itself that would lead to the college having to create a principle-based standard to address that particular area?
Excellent. Okay, thanks. And I have another question here. Somebody's wanting to know, can you explain the term risk of harm and how this is reflected in these new standards?
Sure. So we went over the definition, which is in the standard itself. I mean, the whole goal of the practice standards is to address risk of harm, of course, because the standards are created for public protection and to set the minimum expectation for the profession. So the whole document in and of itself is addressing risk of harm. Some of the things we talked about in the first half are some of the ways that we've revised it so that it more specifically addresses risk of harm in the current situation. So looking at some of the practice trends, the changes in technology, the different needs of the public, and ensuring that the standards are addressing those needs and making sure that it's clear to the profession what the minimum expectation is. I hope that helps to answer the questions.
Yeah, so I'll just let the attendees know there is that little toolbar that allows you to go into questions. You can enter questions at any time during the webinar, and I believe we have two other times that we can pose these questions to Samida and Dana. So back to you two.
Thank you. So no other questions at this time, so we'll continue on with the presentation. Let me just get my screen going here. Okay, so we're actually going to get into the scenarios now, and we're going to look at some following really one patient and look at some different scenarios that would help us apply some of the practice standards.
Mr. Garcia has been your patient for 5 years. He is 67 years old and lives in Ontario. He has bilateral, symmetrical, moderate sensorineural hearing loss and wears bilateral hearing aids. He has a history of ear surgery. Mr. Garcia has always seen you for appointments in person, but he recently had hip replacement surgery and Mr. Garcia is now homebound. He thinks his hearing has changed and it's been over a year since his last assessment. He asks if you can visit him in his home to conduct the assessment. We have a poll set up that Samita will share so that you can answer. And the question for you now is audiological assessment in a patient's home permitted based on the practice standards? So you can enter yes, no, or unsure.
Okay, so we have some responses coming through. Thank you. We'll just wait a few more seconds to allow more people to respond. Okay, thank you to those who participated in the poll. So I'll just close and share the results. And you can see what your colleagues are saying. And let's have a look at the answer. So the answer is yes, audiological assessment in the patient's home can be considered and would be permitted to be considered based on these practice standards. So most of you answered yes. Let's have a look at the standards themselves and how those are written. So looking at standard 1, which is about determining your assessment approach. This is about how we must determine an effective audiological assessment that will address the patient's concerns and generate accurate and reliable results while minimizing patient risk. So this is an overarching practice standard. It would apply in any situation. The principles in this standard would apply across patients, patient group, and across context. So the practice standard goes on to say that there are several factors that need to be considered. First, medical history. In this case, we're looking at Mr. Garcia, who has been our patient for a number of years, so we know something about his medical history. Another important consideration is this the very first time that you are seeing this patient for an assessment, or is it a follow-up? So how much do you know about them in terms of their hearing loss? What are the patient's presenting concerns, their needs and unique characteristics? What is the available equipment? So in this case, going into a patient's home, you need to consider, do you have all of the equipment you're going to need? And what are you going to do if you don't have the equipment that you will need to assess this patient comprehensively? And then, of course, the environment. So the environment in a patient's home or in a school or in a retirement home is obviously quite different from a soundproof booth. You may have less control over the environment. So are you going to be able to do testing that will be accurate and reliable and control for some of the variability in the environment? That is definitely a consideration. So sticking with this standard a little longer, there are 8 competencies with this standard. And let's look at what some of them are. So you'll see that the competencies are always written with this statement first. Audiologists will apply knowledge, skill, and judgment in order to. So first, determine the appropriate procedures for your assessment. Make sure that they are evidence-based and that you're using appropriate equipment. Adapt the assessment, considering the risks and benefits of that adaptation, and determining the implications of modifying or omitting any procedure. So for example, going into a patient's home, maybe you won't have the equipment to do, for example, speech audiometry or emittance testing. So what is the implication of not being able to do those procedures? What's the risk to the patient? And then, of course, monitoring continual consent. Another important standard is standard 2, when we're thinking about this particular scenario, of course, going into Mr. Garcia's home. So this standard is about having the required resources for the assessment. There are 5 competencies with this standard. First of all, being able to determine the appropriate resources, ensuring that the resources are in good working order, infection prevention and control, effectively using and adapting the resources based on patient need. So important considerations in any situation. Here we're talking about going into a patient's home, but this is maybe making it a bit clearer on how these standards are principled and how they're speaking to broadly applicable ideas or principles that would apply in any patient situation. So let's return to the scenario.
You visit Mr. Garcia's home to assess his hearing. Otoscopy reveals possible fluid behind his right eardrum, but you do not have a portable admittance equipment and cannot carry out tympanometry. Air and bone conduction thresholds measured using your portable audiometer reveal an unexpected air-bone gap in his right ear. What do the practice standards require? You'll have another poll, and the answers could be A, stop the assessment immediately, B, do what is reasonable to assess and make an appropriate referral to investigate the fluid in his right ear, C, inform the patient about your results and findings, or D, B, and C.
Okay, so the poll is launched. And we'll just give everyone some time to enter their responses. Okay, thank you very much for participating. So here are the results, and let's have a look at the answer. And I think most people are right on track with this. So the best answer here is B and C. So let's have a look at the standards. So standard 3 is also about resource requirements, and this is about making appropriate and expedient referrals when you don't have the resources or the competency to conduct the assessment for the specific patient. So there are 4 competencies with this standard: recognizing limitations with the environment or the approach or the available equipment, recognizing hearing conditions and gaps in the assessment data that warrant a referral, recommending alternatives when the patient's needs fall outside of what you can provide, and communicating this effectively with the patient, ensuring a patient-centered approach. So in the case of Mr. Garcia, there has been a finding here that there's some fluid behind his right eardrum, and you don't have the equipment required to investigate this. But some of your assessment data is showing that there's definitely an issue with the right ear that needs to be investigated. So to meet this practice standard, you would need to make the appropriate recommendations and make sure that he has that information to know what the next steps are for him. Looking at standard 12, this is about education and counseling, and this is speaking to the minimum expectation that we inform and counsel patients on the results and findings of our assessments and provide them with information on further support. So there are 5 competencies with this standard: explaining and discussing your findings and discussing the implications on functional communication, providing information regarding further treatment. So in this case, for Mr. Garcia, going to see his family doctor, or maybe going to see an ear, nose, and throat specialist. Assisting a patient in addressing barriers. This is an important competency, and I've just highlighted it because it's something that we wanted to emphasize, that helping a patient to address barriers and helping them to access services and supports is an important competency. So for example, Mr. Garcia might feel more comfortable communicating in a different language, or being able to read information in a different language, or maybe he doesn't understand the steps of what needs to happen next. So making sure that he is able to access the information in a way that's easy for him, and that we provide support to help him through this process. And then of course, advocating for our patients for the services that are needed. So let's continue on and see what happens next with our patient.
Mr. Garcia is thankful for all your services and all the information that you have provided. He asks you to share a copy of your assessment report with his family doctor, and he also requests a copy for his own records. There's no poll this time, but we'd like you to think about the question: do the standards require you to respond to his requests? Samita, would you like to lead us through the answer?
Yes, definitely. So in thinking about this, you might be thinking Yes, this is required, and it is required by the standards. So let's have a look at exactly how this is addressed in the practice standards. So looking at standard 14 about documentation, this standard is about how we must document all aspects of the assessment services, including communication with the patient and significant others, and with other professionals. And there are 4 competencies with this standard. Of course, documenting the services and their outcomes, documenting communication and collaboration. And then the 3rd and 4th competency are what speak to the need to respond to a patient's requests or a professional's request. So responding to requests for documentation from another professional in a timely manner, and using your knowledge, skill, and judgment to also provide patients with access to documentation upon request in a timely manner. So this is also important in provincial legislation. So the need to respond to a patient's request for their personal health information is covered by the provincial law, which is called PHIPA, the Personal Health Information Protection Act. And that piece of legislation talks about a patient's right to access their personal health information and that we must respond to those requests. So that's moving on then. We'll continue with our scenario. Let's see what happens next.
Mr. Garcia has a 3-year-old granddaughter who lives with his daughter in a small and remote Ontario town. The daughter contacts you about getting the child's hearing screened. There are no audiologists close by. There is a clinical facility with a trained CDA who knows how to use the equipment and assist with visual response or conditioned play audiometry, with you supervising in real time. The daughter asks if you can oversee the screening of the 3-year-old's hearing by supervising the CDA virtually. This is the child's first audiological screening. We'll have another poll for the question, according to the practice standards, would a virtual screening of the child's hearing be permitted? Yes, no, or it depends.
Okay, so the poll is launched and you can see some results coming through. We'll just wait a few more seconds. Okay, thank you for participating. We'll share the results. And about 30% are saying yes, 15 no, and close to 60 are saying it depends. So let's have a look at the answer and discuss this a little bit further. So the answer is really, it depends. We're talking about potentially a virtual screening. So it's very important to consider, will you be able to meet all of the other standards? And there are several factors to consider in this type of situation. So let's have a look at the practice standards. So looking at standard 15, this is the practice standard on virtual audiological assessment. And it says that we must ensure that a virtual audiological assessment is in the patient's best interest and that it will be feasible, appropriate, and reliable. So if you look at the text below the standard, it also says that virtual assessment must be carefully considered for each patient and must follow the standards for virtual care in Ontario, while also adhering to standards to 1 to 14 in the document that we're discussing today. So there are lots of different considerations here. Prior to initiating, in this case, we're talking about a screening, so not a full assessment, but a screening of a 3-year-old's hearing. But in any case, you must ensure that you can meet all of the standards, and this would include some of the standards we've already talked about. So can you ensure an effective approach to your assessment? Are you going to have all of the equipment that will be needed? In this case, if you're going to be supervising a CDA remotely, the standards are that we have to ensure competency of the CDA because we will be supervising them. Risk assessment and management is always very important, and we're going to take a closer look at that particular practice standard. Consent for all aspects. So in this case, if it's virtual care, consent is going to be about ensuring that the parents or the caregivers understand what to expect, how will a virtual screening be conducted, what is going to be possible to do, what is not going to be possible. For the things that aren't going to be possible, how will you plan afterwards? What types of services will you be able to arrange, or how will you be able to help the family afterwards based on the results of the screening? So all of that has to be a part of the consent conversation, and the family or the patient has to give their consent to proceed virtually. Consent also has to be to conduct the screening virtually and to collect, retain, use, and potentially disclose the patient's personal health information if that becomes relevant. And then you have to ensure that you can make reasonable attempts to conduct all of the required procedures, or you have to have a reasonable rationale for any adaptations that you're making. So sticking with this practice standard, there are 6 competencies, and let's have a look at what they are. So firstly, determining the risk of harm of proceeding virtually. This is going to be based on the appropriateness. So assessing the appropriateness based on the patient's needs and characteristics. So here we're talking about a 3-year-old. Is it going to be appropriate to do a virtual screening? It may or may not be. It really depends on lots of different things that we've talked about. How much support is the patient going to need, or the family? And is this an initial screening or is it a follow-up? That's also a consideration. Determine what aspects are actually possible virtually. Employ evidence-based procedures. If you are going to be making any clinical decisions based on the screening or based on an assessment that's done virtually, what is the risk of that? Are you confident? Can you be confident in the results gathered virtually, or would it help to repeat the assessment in person? And then modifying, limiting, or discontinuing a virtual approach based on the patient's responses, their comfort, and their needs. So it's about being flexible and being able to adapt in the moment. So at this current time, virtual audiological assessment is obviously in development. This is a standard that has to stand the test of time. So today, as we're speaking today, we may not have all of the technology that we need to make this a feasible, appropriate, or reliable course of action in terms of conducting an assessment. But in the next 3 to 5 years, there may be some change in the technology. So the potential risks and limitations, or maybe benefits of this approach, must be explained, as well as how you will collaborate with your patient to adapt and modify based on any risks that might emerge. The clinical rationale that you have for conducting an assessment or screening virtually, it must prioritize the patient's best interest, and that rationale must be documented. And what is clinically justifiable for one patient may not be for another. So what's justifiable for the screening of this 3-year-old, it may not be justifiable for another child. Or if we're looking at an adult, adults are also, each person is unique in their needs and in who they are. So it might be justifiable for one patient, but not for another. Okay, looking at the risk assessment and management standard. So this is not specific to virtual assessment. This is a standard that is always important and applicable. And this standard is about identifying and addressing risk of harm and taking reasonable steps to mitigate the risk of harm. So it's important to remember that risk of harm can be revealed at different points during the assessment. And so it's something that we as professionals need to be considering on a continual basis. And the practice standards talk about risk of harm considerations in 3 areas. So the first is physical harm or patient discomfort. This could be things like risk of transmission of infectious disease, for example. Emotional or psychological harm. So this would be looking at things like, given your patient, will participation in certain procedures cause any stress to them or maybe make them uncomfortable? In that case, you need to assess that risk of harm, and that would be part of the consent conversation. So some patients maybe are uncomfortable with certain emittance testing, like acoustic stapedial reflex testing or reflex decay. So if you know that there's an emotional risk of harm or psychological, making that part of the consent conversation, making sure that the patient understands what to expect, and then having a plan to adapt or modify the assessment based on the risk of harm. And then finally, risk to communication outcomes. So this becomes an important consideration in cases where we are assessing patients who may have less reliable perceptual reporting. It happens with, of course, infants and children. And so the risk to the communication outcomes for children are different. For example, if assessment data is not accurate and reliable, or if results are not communicated sufficiently enough, or the family doesn't receive enough information about the next steps if hearing loss is detected. The risk of harm considerations for a child or infant are different than for an adult, considering the child's social participation, school, language development. So these risk of harm considerations need to be considered, and this is an important practice standard in all situations. So again, just having a look at the competencies for this standard, there's 5 of them. Determining the risk of harm, infection prevention and control, addressing any identified risks that may arise, effectively communicating any risks and the potential impact, and modifying the assessment as appropriate to mitigate the risk. Okay, so we've gone through quite a bit there and didn't take any breaks up to this point, so we're going to stop to take some questions.
Excellent, Samida. So yes, we've got some great questions here now. So one of the questions is, how can we ensure the competency of PDA? Are there any guidelines on this?
Okay, thank you for that question. Yes, so there is a position statement on the supervision of support personnel by audiologists. Okay, just doing a quick technology check. Sarah and Dana, can you hear me okay?
I can hear you very well, thank you. Yes.
Okay, good. I just had a pop-up on my screen. So ensuring the competency of the CDA, I would encourage you to look at the position statement that the college has on supervising support personnel. When you're supervising, it means that you're taking the accountability for the patient care that's being provided. So how do you ensure the competency? Well, it depends on maybe how well you know the CDA. I mean, obviously you'd be interacting with the CDA, talking to them, possibly observing them, working with them before you see a patient with them. You would know a little bit about the thing that they've already received training and any specific training received in their CDA. If there's any that you provide them clinical task that you're asking them to complete, then you with some to ensure how that they're competent, especially if they're going to be using it to use it appropriately. So those would be some suggestions for support personnel.
Okay, excellent. Another question is, are hearing tests under the umbrella of an ENT still required to be in a booth? Sound booth, I'm assuming.
Okay. I think most audiologists who are working with ear, nose, and throat physicians have, a clinical area maybe within the clinic where they're working with the ENT, where they have a soundproof booth. Again, it's looking at risk of harm, right? It's looking at the patient and what is the risk of harm of not having them come into the clinic, not doing the assessment in a soundproof booth. Obviously, the patients that are being seen by ear, nose, and throat physicians are coming with pretty complex medical histories and usually losses. So I would say the risk of harm are really important. If you have a patient who's homebound or who can't come into the clinic, it's really looking at who they are and what is the complexity of their hearing loss. And the answer might be that you can't do their assessment by going into the home. You really do need to wait until you can bring them into the clinic.
Mm-hmm. Mm-hmm. Okay, and what happens if our employer has a policy that does not allow for home visits, for example, due to COVID?
Right, yeah. So if your employer has a policy, then obviously the college would expect that you would follow your employer's policies. The only time it would become a question is if the policy was conflicting with the practice standards in some way, and then I would say it would be good to call me as the practice advisor or to get in touch with a practice advisor in that case. It may be a discussion that you can have with your employer, maybe when things are looking different as the pandemic hopefully progresses to a point where we're in a better situation. It might make more sense then to go and do the home-based assessments or assessments outside of the clinic. But of course, as we discussed in the talk today, you have to make sure that you can meet all of the standards that are required. So I hope that helps with the question.
Yeah, and I'm wondering, Samina, too, even, if there's alternatives, if there is no way around for whatever that patient is unable to come to a clinic, maybe consider alternatives during that time.
For sure.
Mm-hmm.
It might be
another
that,
question was, yeah, sorry.
Well, I was just going to add, just adding to what you were saying, Sarah, maybe attempting something is better than nothing. And that's where your professional judgment comes in, because you know your patient best. Is it better for them if you do at least some of the assessment that is possible versus nothing at all? That's a consideration.
Okay, another question, just checking the time. I think we've got time for one or two more here.
Sure.
Will there be any practice standards for vestibular assessment?
Okay, thank you for that. So again, it will be something that the Practice Matters Committee would need to direct, and there would need to be information to suggest that this area presents some unique risk of harm that needs to be addressed through a minimum expectation for the profession. So over and beyond what the standards are in this document, case history, consent, risk assessment management. Are there additional standards that minimum, like you must meet this standard, that need to be set for vestibular? That is really the question. And if the answer is yes, then the committee would consider the creation possibly of some standards in that area.
Okay. Would you like a couple more questions?
Sure, if we have a couple more, sure.
Okay. Can Shoebox Audiometry Pro be used in initial virtual assessment and following hearing aid prescription?
Yeah, so I've heard of Shoebox Audiometry, and I've had the opportunity to listen to some presentations on it at some conferences. So it appears to be quite evidence-based and a nice tool, especially for patients who are remote and may have difficulty accessing our services. Again, this is where our professional judgment comes in. I think that it would be reasonable to use it with a patient where it seems that it's going to work out for them in terms of what you need to do assessment-wise. Where you need to be open to adapting is when you're running into a limitation. So, for example, with Mr. Garcia, finding an airbone gap and it's inexplicable, and you don't have the ability to really check what's causing it. That's when you need to pivot and be flexible and make sure that you follow up and get the patient the services that they need. It might mean they need to see someone in person, right? So shoebox audiometry, I think, is definitely something you can consider, but you need to meet the standards, you need to ensure that If there's a risk of harm that arises and you can't address that risk of harm with the virtual or the remote testing, then there needs to be some follow-up.
Okay. Okay, I think that's the questions for the moment. And just to reassure any audiologists, any questions that are not addressed during this webinar will be answered following the webinar.
Okay, thank you. I think we do have time to just look very quickly at the last scenario that we have, and it sort of ties in as well to some of the things that we've been talking about here. So let's have a quick look. So we're going back to Mr. Garcia.
6 months have passed. Unfortunately, the region of Ontario where Mr. Garcia lives goes into lockdown. Mr. Garcia contacts you because he thinks there's been yet another change in his hearing. Due to lockdown measures, an in-person appointment is not ideal. He asks if an assessment could be carried out for him virtually. Please remember that Mr. Garcia has been your patient for 5 years and lives in Ontario. He has bilateral hearing aids. His last assessment was 6 months ago, and his medical history is known to you. We have another poll question. Is this a circumstance when virtual assessment could be considered? Do you think it's yes, no, or maybe?
Okay, so you should be able to participate now in the poll. Okay, thank you very much for those who have participated. We're going to close and share those results. And the majority are saying yes or maybe. So let's discuss the answer. And the answer is maybe. Yes, and we were talking about this with the previous audiologist's question. So the truth is, this is a situation we've been facing for the last couple of years. It may be a reasonable approach to attempt some virtual assessment in a public health crisis. And in this case with Mr. Garcia, it's different because it's not the very first assessment of his hearing ever. He's been your patient for 5 years. You know something about him and his hearing loss and his needs and who he is. And again, what I was saying earlier was there's a consideration of risk here. Is the risk of not assessing at all higher than the risk of attempting some virtual assessment? So that's definitely something to consider. And of course, documenting your rationale is always important. So let's move ahead and see what happens with Mr. Garcia.
During the virtual assessment, you subjectively notice that Mr. Garcia's speech reception and perception are lower than expected. You are unable to perform otoscopy, admittance, and evidence-based speech audiometry virtually. Is this a circumstance where virtual assessment should continue? And this time there's no poll, so you can think about your answer and Sumita will walk us through it.
Yes, and so this is a case, and if you reflect on some of the principles in the practice standards, this is where now we are running into some limitations with a virtual approach. We can't do otoscopy, we can't look in his ears, can't do emittance, can't do tympanometry, can't do speech audiometry possibly. Maybe the technology is just not there. So this is not, the standards would say this is not a circumstance where virtual assessment should continue. It's not in the patient's best interest, and the risk of harm is increased if these unexpected results are not further investigated. So this is where you need to be flexible, adapt to in-person services, or help Mr. Garcia locate adequate in-person services so that his ears and hearing can be appropriately examined. And ensure that you're explaining your findings and making appropriate recommendations. So I hope that looking at those scenarios and looking at the standards helped to see how they are principles that we are all expected to apply using our professional judgment. And I think we've reached the end of our time for this afternoon. If there are any remaining questions, please, you can go ahead and type them, and we'll make sure that we communicate with you individually. I just wanted to quickly remind you again that these practice standards are required reading for us in the 2022 self-assessment tool, along with the revised Code of Ethics. And if you have any questions about the standards, please get in touch with me, and I'm very happy to discuss any questions that you have. So with that, I'd just like to thank everyone for joining us for this webinar, and I'll turn it over to you, Dana.
Yeah, wishing everyone a happy holiday season and enjoy the.
Take care, everybody.
Thank you so much.
Thank you.
Of your day. Thank you.